Hello there. The following podcast was recorded at a Monash Partners Informatics and Patient Data Forum on Monday the 6th of February 2017. Hope you enjoy the podcast.
Welcome and thank you very much for coming. Since Jim's opportunely put his head up at the front here, can I just introduce you all to Jim Buttery, who's the current chair of the Monash Partners Data Executive. And many of the members of the executive are in the room and you'll hear from some of those later on today. But what we're going to be talking about mainly today is I'm using this data forum to firstly communicate a bit around the opportunities that are evolving around Monash Partners and the Academic Health Science Centres in a very timely and opportune context with quite a few changes that are going on. But also data is one of the disciplines for the Academic Health Science Centre, so it underpins work that many of us are involved in. And as I said, due to popular demand, we in the end had to be able to audio tape this to reach the others. And I just banned my entire team, who number 90 in my own research group, from coming because I knew there was not going to be enough room. So I have to present this to them tomorrow. So first of all, I'm just going to start by talking a bit about the Academic Health Science Centres. Now, some of you have heard some of this in the theme meetings, but it's shaping up increasingly as we work with our stakeholders, including NHMRC, the Medical Research Future Fund team in Canberra, the state government, and increasingly with philanthropic trustees who are looking to partner more broadly with the Academic Health Science Centre. So as those things evolve, the story updates, but for those of you who heard some of it before, my apologies. So I'm going to give you a little bit of a walk through where we are now. Please ask questions as you go. But if you can keep the background noise to minimum, because as I said, Brendan is taping. And if you do want to ask a question, our lovely lady in red up the back there, Gillian, just put your hand up and she'll bring you the mic so others can hear your question. So I'm going to talk about the Academic Health Science Centre, or as the NHMRC designated us, the Advanced Health Research Translation Centre. That's actually becoming increasingly relevant because the accredited centres, and there are 4 of us that have been accredited by the NHMRC, are designated as ARTECs, or Advanced Health Research Translation Centres, and in fact are tending to use that name rather than the Academic Health Science Centre. It's less recognised internationally but more recognised by our funders, which is probably more relevant to us. Hi, take a seat. So the problem at the current context we have is that we have a lack of a system in both our health services and indeed in research. And this has actually presented a problem that's been recognised internationally but is very much recognised by our government, and by especially federal government, and by some of our funders. This is less of a concern, in fact, for our benchtop research colleagues, where in fact it's much more important that if you're a benchtop research colleague working in a particular area, you partner with the best people in the world who may be in Belgium, New York or Timbuktu. And it's that collaboration that becomes so critical for innovation and development of new cutting-edge technologies. Whereas when we look at applied research in public health and health services research, that actually creates a completely different scenario where it's much more important that we work with our local stakeholders, who are often not academics, in the endeavour to actually undertake our research. And it's quite a different approach. So at the moment in our health system, for example, we have a lack of coordinated or strategic approach. If we have different funders for our primary healthcare system and our public healthcare system. In Victoria, we have 89 hospitals with 89 independent boards that pretty much do their own thing. And there's no platform to get us to coordinate and work together. And hence, we have a bit of a learning platform that is well recognised. But in fact, what's being increasingly recognised, especially in countries like the UK, Scandinavian countries and Canada, is that we can do much better if we start to work together. These observations are also the same around research. So at the moment, in a competitive environment, I'm the academic, I have a great idea, I submit my idea for funding, and if I'm very lucky and it's well received, I'll get funding and I'll go and do it. It may be duplicative, it's often not prioritised, it's often not strategic. Now that's fine if I'm trying to find the next cure for cancer, but if I'm trying to actually improve the health system, it's really not particularly applicable. So what is happening, and in fact this is one of the key drivers behind the Medical Research Future Fund, if you read the relevant strategy document, is that the government's trying to move away from this concept of a lot of puzzle pieces that aren't really coming together to actually form a compelling, complete picture, and move to a more strategic, prioritised approach to research. One of the other problems we have is this concept of translational or unidirectional research, and this is a Victorian document, but there are many documents like this that are available. So what we have is the benchtop researcher doing really important work and the valleys of death the whole way across the continuum. But if by the time we move to the right, we're looking at quality of care, practice and population health, we have this scenario where theoretically the benchtop researcher here is supposed to be able to anticipate and work on the problems that are way down that other end, and it's unidirectional. Rather than having pull from government, stakeholders, consumers and clinicians, we've got a very different approach to this. As I said, it often works well at this end, although there are those valleys of death as we work through that process, but often works very poorly when we get up to the more applied research end. And the other problem is for all of us is this issue about what happens to the research we do. So I've been on another subcommittee of NHMRC recently, and essentially 48% of NHMRC funded clinical trials publish one paper, and often it's baseline data. So we have a system, not from our schools I must say, but we have a system where even getting our research to actually come to fruition and be able to publish in that context is important, but the barriers then to get it out into practice are absolutely critical. So there's a lot of work at the moment around making sure that even NHMRC projects and processes are going to be much more prioritised, much more strategic, and have a process to justify the work that we're doing. And that will include making sure we translate what we're doing. So what about the positioning of the Academic Health Science Centre? So we've come in at the time where there's a lot of recognition that there is significant wastage in research investment, but also not enough investment in research, and we're all struggling as a community, and there is obviously a need for change. So all this started in Australia really with the McCain review, where the panel's vision was actually to bring together not just the researchers, but actually also the health professionals and the investors to come up with a high quality health outcome. What was missing from this diagram is the whole concept of engaging community, because the reality is they are both our funders and the recipients of what we do, and to exclude them is almost certainly fundamentally flawed. So that red arrow in there is my addition around making sure we engage community. This is different to the way we have traditionally worked, where it's primarily academics that are engaged and drive that process forward. So the idea is that we start to move much more towards working together and actually coming up together with the big picture or the full puzzle. Right, this is fantastic. We've got a great turnout. I apologise, there's not enough chairs, everybody. But the concept then is that we start to do this much more strategically and together. So the government's looking at ways of doing that. The NHMRC is working hard around what's going to happen with that, but also the Medical Research Future Fund team. So the idea is, and this has been happening around the world a lot more, there needs to be a lot more pull from community, from health services, from stakeholders, including funders. There's a big push from philanthropy. They are generally no longer interested in just giving us money to do what we want to do. They actually want to be involved in the process, not necessarily control it, and there's a real tension there, but involved in the process of prioritisation and involved in being able to work collaboratively along that journey, so that we've got a lot more pull from research as well as push from the research that we do. The other thing that's becoming much more important, especially in the applied space, is this concept of prioritisation and stakeholder engagement. So before we decide on the most important research we're going to do, we actually know what the national health priorities are. We know what the most important areas are for stakeholders, which include consumer advocacy groups and government. We work in partnership to make sure we've done that. And indeed, those requirements increasingly are going to be vital for even NHMRC funding, so that you're going to need to be able to develop your rationale. And the processes that we've had, where you've got a half-page NHMRC grant that says this is important, and then you've got multiple pages of methods and a paragraph of outcome, is going to change to having much more rationale and process up front, much less focus on the critical methods, although it will vary from across the translational research continuum, and much more emphasis on output. And when you come to the Medical Research Future Fund, that's going to be even more extreme. It's all going to be why we should be funding what we're funding, and a little bit about how you're going to deliver it, and a lot more about how you're going to have impact with what you do. So it's that move to that transition that we really need to be aware and cognizant of. The other thing that we're going to have to do is do our background evidence synthesis, so that you're going to need to have a systematic review, as I said, for most areas of research, and there's even some discussion about that being relevant for benchtop research. So that the big challenge for that we're putting to the NHMRC is they need to fund that. It is time consuming to do, and they need to make sure they provide the resources for it. But when you know what the problem is and what the evidence currently says, then you get to the opportunity to go on and co-design your research. and again, this will vary across the translational research continuum, but for clinical health services and public health research, it'll be fundamental. So the concept of the academic health science centres is in this setting, and the idea is that within the health system, we embed research and we embed education, rather than having silos that run in parallel. Within our research setting, we often have different organisations, we have different, it isn't great. We've got different schools within, different faculties, different schools, different centres, and we often don't even collaborate with each other. But really the idea is that we transcend all of that and actually start to work much more with the key stakeholders at the front end. So the McKeon review came out and talked about the fact that we needed to do this. We had an international panel, very learned panel, who came out and rigorously reviewed the applications that were put forward. And of the 12, there were 4 accredited, and Monash Partners was one of those. We were the oldest because we started in 2011. As you know, in Australia, they're health service led. They're not academically led, and that's actually quite important. It's not what the dean and the university wants to prioritise. It is about what the health services want to prioritise, but how the academics can partner, value add and lead in that space. And that's very much aligned with what's come out around the Medical Research Future Fund. I'd encourage you to read the strategy document. It's not particularly long, but if you actually read it closely, that's what they're very much pushing, is this move towards a prioritised agenda. So one of the things about that is the international lessons said, don't go into this space just for the funding, actually do it for the vision. I would strongly agree with that, but I can tell you that Angela and I have been doing this for the vision for a while. Where is Angela? Oh, there you are. Angela's the Chief Operating Officer. But I don't think we've ever had this many people in the room. And one of the reasons is obviously data, which is a critical area for all of us, but the other reason is that there is some pending pretty attractive pots of funding coming. So we also know that success is based on leadership and vision. So some of our themes are really committed, and there are some leaders of some of our themes in the room who have really been pulling together everyone in a very collaborative effort. Others have not quite engaged as yet, but really we know from the evidence that success in this space is all about leadership and collaboration. And the other thing we know is that change management, this is a complex space. For many of us in an environment of inadequate funding, career challenges, and now we're getting somebody shifting the playing field around how we have to function in the research environment, it's very challenging. And at the moment, it would be fair to say it's been hard to find the vision. It's often been challenging around the skills, especially in the applied research space. The incentives have often not been there. In fact, it's been hard to work together. The resources have been channeled through particular structures and have been difficult to collaborate, and often we haven't had a way forward. So we're hoping to start transcending some of that through the Academic Health Science Centre platform, and one of the most inspiring opportunities for me has been to work with the other academic health science centres. So I have brought together the 4 existing ones, and we've created a national alliance that turned out to be incredibly timely because, 1, we worked together very closely, but 2, having formed that, the Medical Research Future Fund at the moment, which I'll talk a little bit about in a minute, doesn't have a process of evaluation and peer review at the moment. So it's not doing a competitive tender for its first round. But because we went to them as a single entity, a national platform of academic health science centres, we were very well positioned to work with them, and we have done that. So this is our Academic Health Science Centre, and indeed we're having some evolution in some of our disciplines, but you can see that some of the key ones are informatics and patient data, which is an area of interest for most people in this room, primary and community health, quality and safety and innovation, which is a big focus for our health services, and then implementation of health services, research and redesign, and we're going to refine those last 2 as we move forward. The other area that's very important is a clinical research platform. Our main themes are the areas of excellence. It doesn't mean that if you don't fit into those, we don't do it. It just means they're the areas we had to put forward to the NHMRC. And our partners, as you can see down here, now include Eastern and Peninsula. We now cover a population of 3.2 million, which is 16% of the nation's population. So if you could do something in collaboration, you can impact and implement with the imprimatur of the CEOs across those organisations for a very large population. It's very different to the way we perhaps did ad hoc collaborations against all the barriers and silos in the past. The other thing is that these themes in themselves are actual silos. Many people come and say, but I don't want to just work in metabolic medicine. I want to work across X, Y and Z, which is why we're actually following the model at King's College and starting to form clinical academic groups. So out of some of the really good themes, they've said, actually, we need to get everyone together around dementia, or we need to get everyone together around ageing and frailty. That doesn't fit in those groups. And those groups have actually come together and formed some really good collaborations. What about our population? That's roughly where we cover at the moment. However, we're now expanding out to regional areas as well, and our population in that growth corridor is substantial. The idea here is we're creating a community of practice that sits above the traditional silos, both in the health system and in academia. And indeed, if plans eventuate, very much integrates with government without having to work for government. Very fine line to walk. So one of the points about this, and this is a document I've actually got from my colleagues I'm working with in an ARC grant on health system and practice reform. I've learned a great deal working with a very different way of thinking. But in fact, in the literature, there's very good evidence that if you try to do traditional health services research approaches within a single organisation, the research that's done almost never translates and scales and is a wasted effort. And in fact, the research that's been done shows that almost none of the innovations from the very substantial state government investment actually did scale. And part of the reason is there's no platform for us to do that. And so in the Academic Health Science Centres, we've attempted to set up that platform by bringing together the key stakeholders, if you like, and actually creating a platform for people to work together. And in doing so, that platform gives us the opportunity to have prioritised research and to work together at a systems level. That includes for our benchtop research colleagues who may want to go to a particular group, and they've often had to go through individual heads of units or other groups to try and engage from a clinical context. We're creating much better platforms for people to know exactly where to go and exactly who to engage with to try and make that a lot easier. The other thing that's really important is the council CEOs and the deans and directors that sit at the top. So at the moment, if the state government wants to implement something, they've got to go to each one of those 89 the heads of the health services, whereas at least for the health services involved in our area, they're all at the single table. And if we want to implement something that's important or do a project that's important, say in cardiology or any other area, we can get endorsement from the council to do that across the partners. If I can give you a brief example, the number of times we sat around and talked about the fact that we needed to fix ethics and governance processes and we need to make it easier. And nothing happened for years. And the state government's been hitting their head against a brick wall and the NHMRC has been hitting their head against a brick wall. But what we did in bringing this group together and forming an executive with members of each one of the partners was they all got together and said, OK, we need to do this the same way. And because of critical mass and because of CEO endorsement, the ones that were not functioning in the same way relinquished their processes. The ones that had the best processes shared them. And very soon, under the direction of Paul Miles, who's been leading this work, and also Corian, who works very effectively for the partners, we will have much better ethics and governance systems, and now are leading the country in areas like radiation safety. If you put an ethics application in and you want to put in radiation safety because you're doing an X-ray on someone, you have to write that application differently for every different ethics committee because they all interpret the legislation differently. We're now driving that work nationally to have it universally interpreted so everyone does it the same way. So the systems and processes can change and can do so quickly. There's then our partners executive, the themes and disciplines lead, and increasingly they're being very active. Most have a tripartite lead. So we have an important benchtop researcher and often a clinical and public health researcher who work together as a tripartite. The executives have a representative from each one of the partners. They're at variable levels of engagement. Some are very engaged, some are still evolving, but most are now pretty functional. And then those groups work together in particular areas of clinical interest. We now have a staff, it's still fairly skeleton, but we're growing rapidly, and we're building up our public and patient involvement. Together that forms a platform where we can start to work in that more strategic way. So the priorities that came from all of you when we started the Academic Health Science Centre and still currently lead the initiatives in the strategic plan are building a platform around clinical research and ethics and governance. And indeed, we're working with both the state and federal government, engaging with groups like ACTA and also other relevant groups to make sure that that's as streamlined, as effective as possible. The data-driven healthcare improvement, for anyone who wishes to or lives in that space, is a very challenging space. At the moment, even across Victoria, people are doing things very differently. For those who've worked in areas like registries and extracting data that's actually of useful quality, it's almost impossible at the moment. So we have this challenge where data at the moment is not integrated. There's not a national consistent strategic approach. And at the moment, the government is leading precariously towards having that area led by private industry, which is, if you work in the health service, is very scary. However, the academic health science centres have come together as a network and have proposed a model similar to the FAR Institute, where we actually become the hubs and have a leadership role in data moving forward. So there's a lot of work in that space, and there's a lot of interest in that partnership. We're doing a lot more work to integrate with primary care, and that is challenging. Primary care does not trust the large health services. Building those relationships is difficult, but there is also a wealth of data out there, and many people in the room are already working with and researching with those data sets very effectively. The critical other area that people wanted was protected time for leadership and research and translation. The Medical Research Future Fund specifically prioritises practitioner fellowship protected time. That was going to be implemented in a very ad hoc way across the country, but the academic health science centres have come together and are putting forward strategic models for how that could work, such that it's similar across all settings, and there will be quite a considerable amount more funding in that stream as time goes on, which is useful. And also the state government is looking at potentially supporting an initiative in that way, as is philanthropy. The other area we're working on is trying to improve the integration of translational research, and Matt Gillespie will be helping us to do that, where we start to interdigitate some of our very early translational research right into the clinical and public health groups that they work with. And some of the best examples of that, for example, in the UK, is the genetics lab that is right in the middle of the School of Public Health, which is linked to the biobanks and very large registries. And the lab bench scientists are now in the School of Public Health doing their work, integrated directly with that. So they've jumped from the bottom of that translational research continuum right up to the top. And that's what we need to see a lot more of. And it's what a lot of us are moving towards with themed approaches, for example, on this site with a new translational research building. We're building a research culture such that the clinicians, nurses and patients who are in our health services are actually much more attuned to research engagement, and also trying to bring some research rigour around quality, innovation and implementation. The themes, as I said, they're at variable levels of maturity, but they are becoming much more functional, and we've got some terrific examples of collaboration and leadership. We're also working on getting education and clinical research leads. And in terms of funding programs, there's a lot more opportunities on the horizon, which I'm going to talk about next. But just before I get to that point, I might just ask you all, I think, we'll skip that one. So just to highlight the fact that there is a strong vision here, it is very much aligned with government interest. There's a clear understanding of the value of this platform, both at a state level, integrating with Safer Care Victoria and working with Melbourne partners, and yes, it is happening, and very much at a national level. But also the critical recognition that we now need quite a bit more funding. Our partners put in funding. At the moment, our partners put in significantly less than most other academic health science centres, especially in Australia. So University of New South Wales, currently the large partners contribute $500,000 per partner. They're very substantially investing in this platform. Similarly, in other states, we are looking at what that will look like, but definitely the partners have started to see the value. The Medical Research Future Fund, so they currently have $71 million to disperse, has to be out the door before the end of the financial year. They have no process, they have no structure. The people who are in the team actually have almost no understanding of research. All the things that you might imagine in an evolving context with government. But they do have a very clear understanding of perhaps strategy and prioritisation processes, which they hope to bring to the table. And they are working very productively with some of the leadership from the academic health science centres. Because we're not competitive, we're working together as one entity in this opportunity. We've had an opportunity to shape what that might look like. By 2021, if this initiative comes to fruition, it will distribute $1 billion a year. So it's really important. And what we will probably see shift, and this is now personal opinion, is that NHMRC will become much more that investigator-initiated, cutting-edge, perhaps more basic research space, whereas the MRFF will move more like the NIHR in the UK or the CIHR in Canada to being much more about clinical and applied research. That's being worked through at the moment. But in terms of the 71 million, I'll talk a little bit about that in a minute. But the other thing that's happening is in terms of state government opportunities. The state government is also looking at investing into areas such as clinical research and also into safety and quality, and we're partnering with them around those opportunities. The other exciting area is philanthropy. So the large trustees are sick of doing what they call transactional funding, and indeed their strategies actually move from I'll apply, give me money, I'll go away and do my research, to a strategy, and in fact I've seen their documents and worked with them, to a strategy where they actually partner, in a lot of ways partnering to make sure that we actually engage the relevant stakeholders and work in collaboration. So that they're the current opportunities on the table. MRFF is very complex, and when I say that, as I explained before, there's not a process. They have to meet tender requirements to be able to fund, because that's government rules, but they don't have a process for tender yet. So that allows them, for example, to work with the National Alliance of Academic Health Science Centres, because we're tendering as one entity. But it also means that we need to understand what their priorities are and how to work with them. So the process at the moment is what will be funded for this round has already gone to Cabinet, and that should come out. There should be an announcement, we anticipate, around late February. So what they're going to fund has already been decided in a broad context out of the Medical Research Future Fund priorities. And the Academic Health Science Centres, should they be funded, and we're reasonably confident, we think that's likely, will be funded in the areas that were highlighted in the Medical Research Future Fund's priority document, which is basically areas such as care across the continuum, translational care into primary care. Data is a really big one. It's mentioned 2 or 3 times in that area, and it's especially around improving clinical care and improving or reducing variation in clinical care. And the other areas include disadvantaged groups and focusing on health inequities. Now that might sound fairly narrow, but in fact, when you start speaking to the research community, it's actually very broad. So we've had some terrific discussions with groups like Cochrane, who have real opportunities to focus on research around how we translate evidence into practice, which is generic around that. Many of you are already involved in the challenges that we're facing around clinical care variation, and we're incredibly strong nationally and internationally in registries and in the use of data for healthcare improvement. The other opportunities it also offers us is to start to work towards better systems for the use of routine clinical data. And I know John McNeil will shudder when I say that, because at the moment our routine clinical data is of inadequate quality to be able to really improve a lot in healthcare outcomes. But the opportunities to start to integrate that more and to start doing research in those areas are obviously there. So at the moment, that is the scenario. One of the things the government is discouraging us from doing is going out for a traditional expression of interest, investigator-initiated approach. So that if we were to go out to, should we be funded, if we were to go out to all researchers and say, tell us your best project, what we will get is in fact exactly what we get for NHMRC, which is very appropriate for that funder. But we won't necessarily get projects that are prioritised, strategic and coordinated. And in the end, we, meaning myself and the other 3 Academic Health Science Centre directors, have to submit a single cohesive application across all 4 of us. So within that, we don't have to do the same things, but we have to submit a strategic proposal. And to be perfectly honest, I'm not worried about whatever proportion they give us out of the Academic Health Science Centre, out of the MRFF budget this year. I'm really keen to set up the Academic Health Sciences Centres, or ARTECs, to position us for the subsequent rounds of funding. So the most important thing is that we put forward things that are strategic and coordinated. We highlight where they're relevant to the whole of the Academic Health Science Centre platform and to the whole of the national health system, and we actually put forward really successful things we can deliver on. So the approach that we've all agreed to take, and you'll see something about this in the next 24 hours, maybe 48, is that we will be doing a scoping process. So we'll be sending out a communique saying, please fill in. It'll be very quick. You're all in the middle of NHMRC processes. We appreciate that. It will be saying, tell us what areas you work in. What expertise do you have? What do you want to be engaged in and want communication around? What sort of areas and impacts do you anticipate having? So the critical information we need from you, so we know we can go when we've got strategic targeted opportunities and come to you and say, bring you to the table, we'd like to give this opportunity. So when we have a philanthropic group, which we have at the moment, who say, we will give you, X amount per year, and it's a lot of money, in chronic fatigue syndrome, we know where we can start to target. But sending out an expression of interest for everyone who wants to work in chronic fatigue syndrome is going to be very challenging. So at the moment, this is a very rapidly evolving space. Processes are unclear. Everything we do around the Medical Research Future Fund has to be agreed with the federal government, and they're learning their way. And it also has to be strategic and across the academic health science centres and be something we can bring together. So it is challenging, but it is an interesting journey and probably very encouraging, because we anticipate that hopefully we'll have a much clearer idea around what the NHMRC will fund and the processes they'll continue to use, and what the Medical Research Future Fund will be. Their processes are less clear.